Okay, so thank you very much, everyone, for inviting me again. I have the pleasure of meeting all of you from the comfort of my flat. Um, so today I'm going to talk to you about my limited experience with dealing with patients in resource limited settings. My first disclosure is that I'm not a global health expert, so what I'm going to present is my own opinions rather than anything. So it may sound a bit opinionated. I would like to apologize if I'm saying something that sounds too opinionated. Off the bat, I'm going to start off straight away with a patient. This, as you can see, this is a patient that I saw in Singapore, which is not a resource limited place, but bear with me. Okay, so see what's wrong with her. She came to me because she said her legs were stiff and painful and she couldn't walk properly. So as you can see, she's not walking normal. She's a young, beautiful lady, but she's not walking normally. The best way to describe her walk is that if you imagine, if you look at me on the screen, if you pretend that you are going to fix your agonist and antagonist muscles and you walk, you know, just try pretending to fix your agonist and antagonist muscle and walk like a robot. Okay, you can mimic her gait. Okay, fix your agonist and antagonist muscles as you're walking. Okay, so that would mimic her gait. As you can see in the next picture, the pathology in her is due to the interneurons. The interneurons are responsible for marshalling this coordination between agonist and antagonist muscles. So in her disease, the interneurons are not working well, and many of you would have guessed by now, she has this condition called stiff person syndrome, which is an autoimmune disease that's seen in all parts of the world, including resource poor countries, but seen in all parts of the world is due to an autoimmune disease that affects the interneurons. But let me quickly segue to this patient that I saw on one of my trips to Tanzania. You can see this is Kilimanjaro. So this is a slightly remote part of Tanzania. This man who's got this wound in this leg is also complaining of severe stiffness. Okay, as you can see in this picture, he's very, very stiff. He's so stiff that in the next picture, I would be able to lift up his whole leg. Lift up his whole body by just using his legs. So just using his legs, I can lift up his whole body because he's so stiff, you know. And not surprisingly, his abdomen, that's his abdomen, he's got board-like abdominal rigidity. Now, this gentleman's pathology is also in the interneurons, like the other lady, but not due to an autoimmune disease, but due to a toxin that is gone backwards from that wound that you saw, went up retrograde all the way up to his nervous system and damaged the interneurons. Okay, so this is a man who works in the farm, who obviously has not been well vaccinated, who was injured while working in the farm and developed tetanus. So in Tanzania, not only will you see tetanus, but you'll also see stiff person syndrome. So you have to deal with both. So this is my colleague in Tanzania, Dr. Mariki, who wrote this beautiful paper on how she can sort out between the common presentation of tetanus in her parts, in the place that she practices in Tanzania, but also differentiate the very different disorder of stiff person syndrome that you and I would see in developed parts of the world. So that's the challenge. Likewise, this is a patient that I saw in Singapore with classic Guillain-Barré syndrome that you and I know very well, with ophthalmoplegia, bulbar involvement, weakness and numbness of all four limbs. So very easy to diagnose, very common disorder, easily treatable. But what about this sweet young thing that I saw in one of my trips to Peshawar? Peshawar is a city that's at the border between Pakistan and Afghanistan. So we get a lot of patients there from across the border. So she's actually from a Pashtun girl who's coming from the mountains in Afghanistan to the hospital, Lady Reading Hospital, a fantastic hospital at the border between Afghanistan and Pakistan. And she was sent to our neurology clinic. She is only 4 years of age, and she was sent to a neurology clinic by a pediatrician with a very short note saying, "This is a girl with got dysarthria and dysphagia. Please help me manage this patient." So when we examine her, as you can see in this picture, she's got severe nasal speech from bilateral palatal weakness. Okay, so she's got very poor palatal movement and she's got a very nasal speech. She also has got bilateral facial weakness. You can appreciate that she's got bilateral facial weakness. And in the interest of time, maybe I'll move on and say that the rest of the video will show you that she's got severe neck flexion weakness, proximal limb weakness, but normal tone, normal, slightly reduced reflexes, and normal sensation. Okay. So, of course, to me, this was another a classic case of Guillain-Barré syndrome. And the fact that she had upper respiratory tract, a sore throat, treated by the pediatricians 2-3 weeks ago, was the typical antecedent infection that you would see in a patient with Guillain-Barré syndrome. So I turned to my resident, my Pakistani resident who was helping me, and said, you know, if it walks like a dog, looks like a dog, quacks like a duck, and even, you know, in some parts of the world, they eat ducks, you know. So it tastes like a duck. It is a duck, you know. But then the resident turned around and said, doctor, maybe it is not a duck, maybe it is a goose. And I said, why is it a goose? He said, oh, because the pediatricians have actually treated her for diphtheria. And I said, but is the diphtheria confirmed? He said, no, we don't have the resources to confirm diphtheria, but because it's common, it was treated as diphtheria. So that's when my heart sank, because I knew nothing about diphtheric neuropathy, because I've not seen a case of diphtheric neuropathy. But at that moment, something I remember reading in the textbooks about the differentiating feature between diphtheria and Guillain-Barré syndrome is the so-called inverse Agar-Robertson people. So all of you know that Agar-Robertson people is when the light reflex is poor, but accommodation is intact. But in the inverse Agar-Robertson people, the light reflex is intact, but the accommodation is poor. So we said, let's test this in this lady and see what happens. So as you can see in this video, a pupil responds fairly well to light. But in the next few seconds, I'll be trying to get this very cooperative, intelligent girl to converge. And her pupils will not accommodate at all. Absolutely no accommodation. So finally, with that, we decided that she must indeed have diphtheric neuropathy. We supported her and would like to report to everybody that she made an uneventful recovery and walked out of the hospital well in the next few weeks. Now, what is interesting is that unlike other parts of the world, diphtheria is not uncommon in these parts of the world. Why? Because unlike many parts of the world, vaccination records are not reliable, and you have to rely on the mother's memory to know whether the vaccinations have been completed. So because of that, many children end up incompletely vaccinated, and so diphtheria, measles, and other infectious diseases were not uncommon in this practice. Okay, this is another patient I saw that appeared to be Guillain-Barré syndrome. Well, actually, I didn't see this patient personally, but it was shared with me by my good colleagues from Mumbai, Dr. Satish Kadilka and Dr. Rajesh Bani. Okay, this is a patient that looked like Guillain-Barré syndrome with all the classic features. The only thing that was atypical was that he had too many cells in his CSF. Okay, but nevertheless, the doctors thought that it was Guillain-Barré syndrome because it is the commonest disease after all. Even in rural parts of Maharashtra. This was a rural part of Maharashtra in India. So they treated him as for Guillain-Barré syndrome, but there was something atypical. He started developing diffuse fasciculations. Okay, the autonomic features, the respiratory failure, and all these things were consistent with Guillain-Barré syndrome, but diffuse fasciculations, that was a bit odd. And then he developed severe hydrophobia and aerophobia. And then unfortunately he passed on. At that point, the history became obvious that actually a few weeks before admission to this hospital, he had been bitten by a dog, you know, and there was actually a wound on the left side that was partially healed. That was the site of the dog bite. And this man had the unusual form, the paralytic form of rabies that mimics Guillain-Barré syndrome. Another example of vaccine failure, this time of the dogs. Okay, so this is so emblematic of our current situation now. We are going on and on about finding vaccines for COVID and trying to control it. But we know that for years and centuries and decades, many parts of the world, that there are many diseases, polio, diphtheria, measles, rabies, that are going on because the administration of vaccines have failed. So I'm not as optimistic that when we finally do find COVID vaccines, that the Southern Hemisphere will get the same results that the Northern Hemisphere is going to get in terms of the efficacy. So lesson number one that I have learned when working in resource poor countries is that the diseases that we see in developed parts and the developing parts are similar. Guillain-Barré syndrome versus diphtheritic neuropathy, stiff person syndrome versus tetanus, but they are also different. Similar, but also different. So the clinician who's working there has to be super good, because now not only has to deal with diseases that are seen in other parts of the world, but he also has to deal with all these complex nutritional and infectious diseases that have different sort of permutations in the resource poor parts of the world. For example, even standard Bell's palsy, that's so common in, this is a standard Bell's palsy in Singapore. But when I was working in Africa, even unilateral Bell's palsy was a harbinger of HIV. So almost all Bell's palsy patients have to be tested for HIV because HIV is common. Similarly, spastic paraplegia in children, there are many, many causes in many parts of the world. But in northern eastern Africa, you have to deal with konzo, which is a disease of nutritional toxic spastic paraplegia. And interestingly, disproportionate amount of women were affected. So initially it was thought it was some kind of complex genetic disease because the mothers and daughters were affected. But actually, you know what is the reality of it? Because it is a nutritional disease. Okay, whenever there is excess nutrition, it was the males, the men and the male child who got the food, and the women were the ones who were starved. So it was a disproportionate disease affecting female children. So that is the reality of neurology in resource poor countries. So you need to be extra good, because not only must you know of diseases that happen in other parts of the world, but you need to know about diseases that present in the same way, but have different connotations, different etiologies and different managements. Lesson number two, when I'm working in Singapore, I've got a whole entourage of junior doctors, nurses, physiotherapists, occupational therapists, speech therapists, social workers to help me. But when I'm working in resource poor countries, if I have an assistant who's partially trained, it's fantastic already. So when I was seeing this girl, this lady in Zagazig, which is a small city about 2 hours away from Cairo in Egypt, she came to us for sequential weakness of the limbs, and I had a very basically trained allied health medical personnel. I had to keep things very simple and say, look, let's decide. And I have to use very simple algorithms like this. These are very important when you work in developing parts of the world, because you cannot give complicated algorithms, because you're dealing with people who may not be fully trained as many of us are in developed parts of the world. So I had to start off by saying, let's keep things simple. So this lady, does she have upper motor neuron or lower motor neuron findings? She had lower motor neuron findings. What's the next thing we did? The resident managed to figure out whether the pattern of weakness was proximal or distal. In this case, the patient had distal weakness. The next thing I asked him is the sensation normal? The patient's sensation was indeed abnormal. Then the next thing is it a glove and stocking sensory loss or patchy sensory loss? Now, this kind of simple algorithm was well within the capabilities of a basically trained allied health personnel. So he was able to tell me, yes, indeed, she had sensory abnormalities, but it was patchy in nature. So what are the differential diagnoses? Well, vasculitis or leprosy. Now, vasculitis is a disease that you will see in all parts of the world, including developing parts of the world. And this lady had eosinophilia in her blood. She had pulmonary infiltrates, adult onset asthma, and she had a typical vasculitic rash. So with that, we made a clinical diagnosis of vasculitis, started on immunosuppressants, and made her better. But then you'll be wondering, vasculitis is a disease that you see in any parts of the world. So what am I talking about in developed parts of the world? Then in the same place, we saw the next patient was a patient who comes to me with this story that he's also weak. And then again, when we use the simple algorithm, lower motor neuron, yes. Pattern of weakness, distal, yes. Sensation abnormal, yes. Is it glove and stocking? No, it was patchy. Then the next question is it vasculitis or the other differential diagnosis, leprosy? And then we said, okay, let's look for specific distinguishing features of leprosy. And we found the thickened nerves. We found the hypopigmented anesthetic patches. We found the mutilating rash, mutilating joints in the hands. And with that, we made a diagnosis of leprosy and started the patient on treatment. Okay. Now, if these patients were seen in Singapore, we would have the luxury of biopsies, histological proof to prove that this patient had got eosinophilic vasculitic neuropathy from Church-Strauss syndrome, the first patient, and the second patient had tuberculoid leprosy, because we could demonstrate a paucity of mycobacterium in the skin and in the nerve, and the typical changes in the nerve. But when you're working in under-resourced parts of the world, you're dealing with very limited resources, then you have to really use all your senses, all your medical clinical senses to make the diagnosis, because you don't have the luxury of a large entourage of specialists with you, or services that are available to make life easier for you. So when you're working in resource poor countries, keep things simple. Use simple algorithms, clinical skills, and everything has to be basic clinical examination, rather than sophisticated investigations and sophisticated technology. Okay, lesson number 3. Okay, lesson number 3. Well, I may sound a bit philosophical, but I've discovered that the earth is not flat, because all of us know that. But I also discovered that the earth is not round at all. In fact, it is a pyramid. Okay, it's a pyramid where the majority of human endeavor is actually concentrated in the apex, where the rich people live. Okay, although the large majority of the world's population are in the base of the pyramid, majority of what we are doing, whether it is the iPhones that we are using, the computers that we are using, the technology that we are taking for granted, doesn't reach the base of the pyramid at all. This is well known among business circles and among the economists. But why am I talking about this in a medical conference? Well, I would like to say that the base of the pyramid is even wider when it comes to healthcare, because a lot of what we are dealing with, whether it is the things that we talk about in the conferences and all that, has got to do with things that are happening in the upper part of the pyramid. So let me give you an example. We go back to Guillain-Barré syndrome again. Guillain-Barré syndrome is a common disorder, is the most important cause of peripheral neuropathy all over the world. Now, the mortality is less than 1% in developed parts of the world. In fact, many parts of the world, if one person dies from Guillain-Barré syndrome, it's a major event. Okay, we're not talking about 1%. We're talking about one person. One person dying from Guillain-Barré syndrome is a big thing. But I have colleagues in Bangladesh, in Dhaka, okay, where they have published that their mortality for Guillain-Barré syndrome is 10%. 10%. Okay, and Guillain-Barré syndrome is not uncommon because of the high incidence of diarrheal illness. Guillain-Barré syndrome is actually quite a common disorder, but 10% of them die. Why? Because they don't have ICU facilities when they develop respiratory failure. Immunoglobulins are not available. Plasma exchange is not available. Standard treatment is not available. But if you go to any conference on peripheral neuropathy now, you know what they talk about at the peripheral neuropathy? They talk about eculizumab. Why eculizumab? Because eculizumab will improve your mortality, morbidity of Guillain-Barré syndrome by a further few percentage points. But for who? But for this apex, not for the base. The base has not even gotten ICU care, not even gotten immunoglobulins, not even gotten plasma exchange. Okay, and in most conferences, people are talking about high-tech treatment that only benefits a small apex. Okay, and that's because of the power of the pharma and the way academic medicine is practiced. So I would like to propose that we go to what Dr. Prahalad is actually a business person, economist. He talks about the fortune at the base of the pyramid. Of course, we don't have fortune at the base of the pyramid when we come to medicine. We have misfortune at the base of the pyramid. So I would like to propose that we concentrate on the misfortune at the base of the pyramid, and we think about measures that would work for the base of the pyramid. Now, their theory is that things that work, if you rely on capitalist trickle down, okay, things that work for the top and wait for the things to happen in the base, it may not happen. So they suggest that you need to have innovative solutions for the base of the pyramid. So likewise, for medicine,
you've got 5 more minutes to go.
Okay, I'm finishing now. Okay, so base of the pyramid. So what are the things that work for the base of the pyramid? Well, things that work for the top, by the time they trickle down, thousands and thousands of people are going to die. So you need innovative technology for the base of the pyramid. Innovative technology like this, the Bangladeshi doctors have come up with what we refer to as small volume plasma exchange. It's So likewise in Myanmar, that's what they do. So they take blood from the patient, they remove the red cells, transfuse the red cells and throw away the plasma. Okay. So by that, they can exchange the patient's plasma volume many times a day and effect small volume plasma exchange. And I must say that this innovative technology was actually first effected nowhere else but in Sri Lanka by Dr. Pires and his team. Okay, so I'm proud to say that Sri Lanka was the first country that actually innovated this technology that is being effected in many parts of the world to treat patients with Guillain-Barré syndrome because they cannot afford standard treatment. Likewise, rehabilitation is hardly available in many parts of the resource-poor countries, in many resource-poor countries. So like, for example, this man with Guillain-Barré syndrome who had severe paraplegia. So what did this lady do? She didn't give up. She found this place called the Live Well Center in South India, okay, which doesn't say Guillain-Barré syndrome stands for Guillain-Barré syndrome. It stands for get better slowly or growing back surely, okay? And they made sure that this patient rehabilitated back to normal function. The reason why they do that is because they have an alternative model. Instead of having expensive physiotherapists, they employ girls from nearby villages who have minimal education, and they have 1 or 2 physical therapists, 1 or 2 physicians, and they train these village girls to become physical therapy technicians. Okay, by doing that, they brought down the cost so low so that they can effect treatment for patients like him in remote parts of South India. So again, disruptive technology. We had some hand in some disruptive technology. Some of you who worked with me are familiar with some of the projects that we have, like for example, Project Albatross, for example, will try to bring in specialists to remote parts of the world. Project Nightingale is a project to bring doctors from remote parts of the world for conferences in developed parts of the world. And Project Woodpecker tries to bring in essential blood tests, for example, acetylcholine receptor antibody, NMO antibodies and all that, to remote parts of the world by bringing down the cost of this, medication. So in summary, my take-home points are 3 lessons. Number 1, the diseases that you see in resource-poor countries are similar to in developed parts of the world. Similar, but have their differences, because not only do you have to deal with these common disorders that are present in developed parts of the world, but you have to deal with the permutations of these diseases because of the associated burden of poor nutrition, tropical diseases, and poor vaccination penetration. Now, care in developed parts of the world can be multidisciplinary, can be sophisticated, but care in resource-poor countries must be very basic, must be very easy to apply by even people with minimal training, and must be founded on basic clinical medicine. Cannot be sophisticated technology. And finally, you cannot wait for trickle-down capitalist politics to come down and help the poor in the base of the pyramid. We need innovative ideas to positively disrupt this pyramid so that technology that is peculiar, that doesn't apply for the apex, but technology that is peculiar for the base of the pyramid and helps them in ways that are very innovative and disruptive in the application. So with that, I would like to thank the organizers and like to end off with this, one of my favorite quotes from Franklin D. Roosevelt. You can get my notes from this QR code. And for those of you who are taking copies of my presentation, please respect the privacy of my patients who have agreed to be filmed. Thank you very much. And
thank you very much, Prof. Umapathi. That was a very interesting lecture. Since we are running out of time, I'm sorry we don't have time to take any questions, but we will try at the end. If there is any time left, we might be able to answer your questions, and we will have to move on to the second talk now.